to get a little comfortable with some public speaking and teaching. So I might have you guys teach each other too. So I'm kind of thinking how to structure this, but we'll have fun. So any questions about the syllabus? Any thoughts on that? Like read through anything that you're confused about or you're wondering, or is it pretty straightforward? Good, okay. But I'm not offended if it isn't, you can tell me. There's some questions you have. All right, so that's our syllabus. Okay, so I have a question. Do you guys want to take a break now? Go to the bathroom for a minute, and then when we get back, we're going to do I have a little lecture. This is probably going to be our shortest day, so I'm not going to keep you the whole time. But why don't you take a break, go to the bathroom, and then we'll finish up with my lecture. What, sound good? All right, go. Take a break. And do you know where the bathrooms are in this building? Did anybody tell you that? Yeah, it kind of helps to know. So if you go out here, I'll show you guys. There's an elevator here, and you go down a floor. You can take the elevator, or you walk away and get down the stairs. So a lot of us, everybody just takes the elevator now. Yeah, bathrooms down there. Yeah, you're welcome. Yeah.
How was Kim when you showed up? Was she okay? Okay, oh good. Before I forget that.
This, so you put the parking ticket in first, and then you put this in second. Okay. Yeah, that's all you do. So where are you guys staying? Do you live like? Oh, I used to live there. Yeah, I was on the 18th floor. Isn't it neat, the big windows in the city? Oh, do they still have the beach volleyball thing? They still have that? They used to have beach volleyball, a pool, a gym, and then there was like a tanning salon, some type of, and then it was like a grocery store at the bottom. Is there still a grocery store there? No. That was nice, having a grocery store. Yeah. But it's neat because you can walk. Do you guys, have you seen any of the hockey games?
We saw them before.
Penguins,
right?
Yes.
Penguins.
Yeah.
In 2006, right?
Yes, in 2016.
Well, you guys were here in 2016?
It used to be an exchange student.
Oh, wow. Oh, that's really cool.
Summer semester.
Okay.
Just for 3 months.
Very neat. So you kind of knew, so that wasn't as scary coming here for a year, knowing that you'd already been here.
Yeah.
That's nice. Yeah, so, yeah, you'll have to check out the hockey games. And then baseball.
The Pirates.
Yes, the Pirates.
Yes.
We don't understand the game rule.
It's always just like they're running around.
They hit the ball and they run the bases. You try to catch it.
That's funny. The ballet is really good too at the Benedum. Like if you like ballet, like the.
And they have plays down there too.
There's the cultural district. It's nice. Like we have a pretty good like the theaters really. So the symphony. They have really good performances. Heinz Hall. Yeah. Good. All right. Yes, I'm gonna have my lecture. Not today. Yeah. Okay, good. So this is this the front of the room?
Yes.
Okay. Good. Perfect.
但是问题是，他就问你开学了，是不是已经开学了？为啥是以前来过，然后你的信息不在这里，就是在这个学期收分的下，这个是差不多。因为我跟他写的时候，就是说我进不去那个网站，
这是怎么那么冷啊？我感觉每天上课都要带羽绒服。
超级冷，就是你知道那个之前我们上课就是坐那个书，然后就鼻涕啊，
体质有关系。你真的不冷吗？啊，你学？
如果我穿了短袖，短 T 恤，我肯定会冷，所以我才能穿那个。你知道我那个人家从小会的就是喝冷水，心情都是就还得穿短的。
为什么？
你要是上实验课啊。
那我可以再穿外套啊，我把它穿里面。
他是要求我们带，但是没说要穿。
对，
带上。就是
这还是课的，我好想来喝杯热的。
一定要运动。
我还以为你拿出一杯热的来让我穿进去。
我还是在寝室里烧好了带。你早点说，我给你带来。
你看我带了，这个水，但是我实在是不想喝。
凉的热
啊，温的。
那温的不会比你热的？
混了。
我早上是完全起来，那眼睛都睁不开了。
你晚上几点睡？几点起？8
点钟。
睡9个小时啊！昨天晚上1点半睡的，然后今天早上7点半起的。
我每天的睡眠也就6个小时，超过那个我就会自动醒过来。不，我之前这样，我之前睡得早起不了，但是现在我睡得晚一点，但是我起不来。就是我刚来说，我12、3，就我们都是同龄人。然后就是我刚来的时候，我是你的小学妹，每天
90，你们是九几年
？95、96。
哇，原来是95、96的呀，那么厉害。
只是那样。那你们晚上
要不要吃啊？
你是很咸是吗？
啊？咸的不行，会胖，要不要吃？
你们买一点饼干。
经典原味。
这多少钱？啊？真有钱。
真的咸。
我不知道还多少。
我们都没有敢买其他味道的，因为这个很好吃的，但是这个是真的
这个在
咸吗？不咸啊。
10几块钱。
啊，19块8。
哦呀。
在这里要24。
24刀？
不是24块。
24块是吗？哎，他们之前的大一的8瓶是10，扣吧。
8瓶11刀啊？
对，但是
反正我也不会再买了。
这是他们的那种速溶咖啡啊，跟像
好喝，难喝死了。
去超市买自己泡。
我其实很少喝咖啡，我只是偶尔喝一下。喝茶，从明天开始带茶。
你带了什么茶？
杭州的那个龙茶，这是不是要拿下来？这是不是要拿下来？
故意放，看他会不会说什么。
放在这里，然后一不小心就吃掉。
Okay, clinical thinking. So next time you guys come, I'm going to add another lecture. You don't have it, but I'm going to put it up there so you'll get it. So I'm going to teach you something a little bit different, but this is a nice beginning kind of segue into clinical thinking, right? So clinical reasoning, how you figure out what's in your patient's head, what kind of questions do you ask, how do you connect with them. So we're going to go into that. This is a model. I think like my first thought about the model was it's kind of confusing at first. It's like a logarithm. So I'm going to teach it to you, and it is on the test, this stuff, so you have to know it. And then I'm going to add a little bit more to kind of apply it, and we'll apply it next time. So since it was so important to all of you to have that clinical reasoning, I'm going to emphasize that in this class. Okay, so we'll go into that a little bit more, and I'm going to teach you some of the fellowship stuff. Oh, and you know what? If this is wrong, did I get that right? Is that right? Okay, let me know if it's
明明
wrong.
不对，也说对了。
If I have a bad word up there or something, that'd be awful. Okay, so this is the hypothesis oriented algorithm for clinicians, abbreviated HOAC2. I know, this is when you're like, oh. But basically it's an algorithm. It helps you think each step. Because when we as therapists, when a patient comes into the room, we need to have a certain set of hypotheses, right? So we need to be a scientist. What happens is we often see a patient and we have our internal bias. We think, a patient comes to us and they walk in like this. What do we think might be wrong with them?
Low back.
Yeah, low back, right? I mean, that would be my first thought. Or it could be scoliosis. Still a low back issue, but it could, so there's a lot of things that could create this, right? It could be a hip issue. So coming up with that initial hypothesis list when you're talking to a patient will help you, right? So this is a nice model that kind of takes you through the step-by-steps, okay? So we're going to, the purpose of what this little talk is, and again, it's not going to be long, I'm not going to keep you here long today. So this is the get out of jail free card to enjoy the warm weather day. But we're going to apply it, okay? So this is the whole model. It's pretty long, but this is what should be going on in your head when you're working with a patient. And the challenge is when a patient's in front of us, it's really hard when you're getting that subjective exam to be thinking at the same time, isn't it? Like they're telling you information, and at the same time, your brain has to process that information and then react as that information is providing that you're getting that information, right? So you have to make that constant critical thinking. So a good clinician is constantly thinking. So whenever you feel comfortable in the clinic, I always say that's a red flag. Meaning, when you feel too confident and too comfortable, that's when you're going to make errors. That's when you're most at risk for hurting a patient, right? When you feel confident. So it's good to be confident, but it's better to constantly second guess and continue to critically think, right? So I caution you with that, and I've learned that through the years. Whenever I felt really confident, that's when I would probably slip up and make a little bit of an error, because I just would, And how busy are your clinics where you guys work? How many patients do you see in an hour? What's it like?
In an hour, three
An hour?
3 to 4.
3 to 4. That's a lot.
Yes.
That's a lot. So you get about 15 minutes a patient, and then where does that patient? Do you have like rehab aides that work with them, or who works with the patient after that? That's it. So they're only there for 15, 20 minutes, and they're done.
But we cannot educate them.
Wow. So the patient goes by themselves and does whatever you've taught them or whatever you've done. So you have to be really efficient. That's hard. That's really hard. But, some of the better clinicians, right, are exposed to that because it makes you very quick, right? Because when you have a full hour with your patient, it's a luxury. It's really nice. But you can kind of get lazy a little bit, right? And you don't have to, but you have to really be on your game if you're seeing that many patients. So, yeah, and the thing that you battle, too, when you're in that environment is probably fatigue. You get tired, right? Your brain starts to just become mush by the end of the day, right? And so it takes a lot out of you to constantly think that critically, but you have to, because you don't want to make a mistake and hurt someone or, not get them where they need to be. Okay, so the first part of this is collecting our data, right? So it's just like a scientific experiment, like research, right? We're getting our data. So we're getting that patient information. When the patient walks in the room, that tells us information, right? Do they walk into the room or are they already there? In the hospital setting, they're probably already there. You're going to their room. But in an outpatient clinic, do you guys go out and get the patient and bring them in, or are they brought to you? They're brought to you. Okay, and that's a challenge because one of the best things is to spy on your patient and see them walk when they don't know you're watching. And we'll get into that when we go over gait, because people walk very differently when you say, oh, I'm going to watch you walk. They're like, okay. And they try to do it the best they can. Versus when they get out of their chair, in the waiting room, and then they might walk in the waiting room into your room and sit down. You might have missed all of that, right? So that would tell us something totally different about that patient than after we get them up on the table, we do tests and measures, and then they're warmed up a little bit. We say, okay, I'm going to watch you walk. You might miss a key factor about them, right? So getting that initial data can be challenging. So we're developing, when we get this data, we're developing our initial hypotheses. We're coming up with our primary problem list. And so in this moment, we have to decide too, does the patient belong here? So, and it's different in the hospital setting. It's different but in the outpatient world, right? The patient comes to us and we have to make a decision, is this patient indeed here in the right place? Now, do you have so it's different, I think, for you. In my clinic, I can say, no, I think the doctor was wrong. You're not supposed to be here. You need to go elsewhere. Can you guys say that? Maybe? You say no? And I mean, we wouldn't say, no, I think you're wrong. But what we would do is we would call them and we would say, I have some concerns about Sally that came in today. There's some things that I've picked up on that she didn't tell you. Or, there's that fine art of how you communicate that. But we really, even though they're said to you, how much time do your physicians get with their patients before they send them to you?
Difference.
Hospitals, for example, if the outpatient may during the stay for about 3 to 5 hours before, and if they are inpatient, they need to send about 24 hours before.
Okay, so that's in the hospital setting.
And they are also different for the inpatient or outpatient.
Right. So for outpatient, in an outpatient world, how long would a physician do your physicians average per patient?
3 to 12 hours.
With the patient, 3 to 12 hours. Oh wow.
Yeah,
So
it depends on the different region of the patient.
Okay.
Some may.
Oh, you mean 3 to 12 hours before they see you? Okay. But what about when they assess you? So if I had an appointment with you and I'm your doctor, how much time do I get with you before you? How long is your visit with me as a doctor? Oh, that's good. 20 to 30. In the States, they've got 5 to 10 minutes. Yeah. So did you do a full eval for a patient? 5 to 10 minutes, right? Mm-hmm. Yeah. So
They walk into the physician's office and say,
Examination or the treatment?
for the examination. Okay, so it's the same. So it's about the same. Okay, for the exam. Okay. And so if you think about how rapid that time is, and then there can be some errors that are made, right? You can't get all of it. I mean, in that amount of time. And that's the luxury about our field. Because yes, we have 20 minutes with our patient, right? But you see them several times. So you're going to see them not just once. So the doctor will see them once and then follow up with them later on after you've worked with them. So what might happen is when you're working with them, something can come up that you didn't pick up on, right? They could have a little spot on their leg that over time becomes a wound that you need to communicate with the doctor is there, right? So we're always thinking, is the patient appropriate to be here in this moment, or do I need to make a referral? Was my point with that, right? So we're always thinking about that. And we're getting there, we're coming up with how we're going to examine our patients. So I'm going to go into that more next time about how you kind of get into that a little bit more in detail, because I have a good process for that. So we're constantly refining our hypotheses, right? So what we might think is our primary hypothesis, we think this is a back patient. As we ask them questions, we might shuffle that hypothesis list, right? So we might think, yes, this is a back patient, but as we talk to them, they're pointing more in here, and they're telling you they have trouble putting their socks on or their shoes on, right? And you're getting more questions. They have trouble getting in and out of their car, but it's this motion that they have trouble getting in their car, and the pain is more here, but they told you it was their back. You might be thinking now, maybe this is a hip issue, right? So we might be shuffling that hypothesis list. And that is important when we come up with our objective exam, because we need to figure out, what are we gonna exam, right? Am I gonna even look at the hip with this patient? So in this case, I am gonna look at the hip of this patient. I do wanna see what's going on, right? So coming up, that's what they're talking about here, kind of refining our hypotheses. And then we're coming up with non-patient identified problems to the problem list. So for each problem that they're saying, so basically each thing that they're reporting, we're getting an idea of what might be going on, what body area, how we're gonna identify that and move on, okay? Okay, oh, so this goes in here. Okay, yeah. Okay, so I guess I should ask you, what kind of examples, well, we already talked about that. I gave it away. I do that all the time. Okay. Okay, so, all right. Come up with our hypothesis. All right. So, tell me what kind of things would tell you that you need to make a referral, that you need to send this patient elsewhere. What might pop up? What kind of things might you tell you, oh, I don't know if I should treat this patient this day? What about in the acute world? Yeah.
There are symptoms that are
Acute inflammation. Good.
such as thrombosis.
Thrombosis. Yes.
And some serious problems in the
Cardiac pulmonary. Exactly. Right.
So they're hooked up to all kind of machines. You're monitoring their vital signs, and what happens when they go supine to sit? Does their blood pressure plummet?
Yeah, we may do the vital signs such as to check the temperature, respiration, and make sure this is not in a high pressure.
Right. That's right. Okay. What about in the outpatient world? Other settings. Any thoughts?
You're treating a patient for a few weeks. They're not getting better. Anything that you would want to refer them to a physician for?
I have a question. So I have a patient. This just happened 2 days ago. Okay. I evaluated her once. Really nice woman for her back. So I took hold of her back, and she was, really kind of, funny and laughed. And so she came into me and she started her exercises, and she got off, and she was riding the bike, and she got off the bike, and she told me that she was going to a concert that night. And I was like, oh, that's really nice. And so then we started walking, and she's like, I'm going to be going to a concert tonight. And then she looked up and she's like, I just told you that, didn't I? And I said, yeah. And I said, are you feeling okay? And she's like, I don't know, I really don't feel that good right now. And I'm like, okay. So I just, in my mind, I'm thinking, what's going on? This is weird. And her whole affect changed, meaning she is usually kind of a bright, spunky kind of talk. And she had more of a plain kind of face and kind of not really with it. And she's like, I'm fine, I'm just really tired. And I said, how tired are you? Right? Because you have to have the next good question, right? So when you're talking with your patients, you have to have the next best question. So I said, how tired are you? Is this your usual tired? And she said, no, I feel like I could probably sleep for a good 5 hours. And I said, is this normally how you feel? Have you ever felt this tired before? And she's like, no, I don't know why I feel this tired. So what might be going on with a patient like that in the outpatient world? What am I thinking? What's happening with my patient? What do you do? Good. So she said evaluate again and find out what's going on. So what things might I want to evaluate? Am I going to look at her back in that moment?
We'll try, I think we'll try to find the reason makes her feel tired.
Yes. So what would be a body system that might make somebody tired? She just got off the bike. And she had that reaction to riding the bike. I think I heard it. Oh, kidney. Could be kidney, right? Could be, yeah. Or heart. Right. So maybe something non-musculoskeletal, right? So even though we're musculoskeletal, that's our primary, we still have to be able to, you're going to learn all that, of course, over this year. So I had to take her vitals, right? I needed to know what her blood pressure was. What's her heart rate? So I sat down and I took her blood pressure, and it was 250 over 120. Her norm is 110 over 78. Yeah. So I said, I actually had my colleague come over because then I thought, I second guessed myself, right? So I had my colleague come over and I said, hey, and I didn't say anything. I said, we just take her blood pressure. I'm not sure if the cuff's working. So he got another cuff out and took it, and he said, he pulled me aside. He's like, I know. And he told me the numbers, and it was just the same as mine. And so I said to her, you know what, you're not driving home. And she's like, I'm fine to drive. I said, nope, you're not driving home. Sorry, She's like, I don't have a ride home. I said, well, we're going to have to find you a ride. Either we're going to call the ambulance, and they're going to pick you up, or you're going to have to find someone that can take you, and you're not allowed to go home. You're going to the ER, or you're going to MedExpress. I gave her a choice. Because in the States, I can't force someone to get on the ambulance. At least in my, if a patient outright refuses, I have to honor that, but I can certainly not let them drive, because that could harm someone, right? So I said, you're not allowed to drive. So anyway, long story short, she found a ride. Her husband came there. She was admitted that night to the hospital. And the reason they still don't know, they're still exploring what's going on. She came into the clinic and thanked me. And she said, you know what? I think you saved me from probably killing somebody on the road. She's like, if I had gotten in a car and driven, I probably would have killed someone. So my whole point, in this point is, even though wherever you're practicing, you never know, it's the human body, right? So things happen. And that's why this information is so important and so vital, that we're always thinking. So if something doesn't seem right, it probably isn't. And it can be really subtle, right? Something just as subtle as she said something twice. She's never said something twice like that to me. So I knew something was a little bit off, right?
And the flat effect of her face. And,
yeah.
I mean, you never know. In a hospital, in a clinic, are they diabetic? Do they have a history of heart disease? That's stuff that you have to know right off the top of your head.
Right.
5-10 minutes on a bike should not tax a body that quickly to do something so dramatic. So, you have to figure out what's going on with that patient.
Mm-hmm. Yeah, okay. So we need to know, do we need to make a consult? Do we need to make a referral? Okay. For each problem list, right? So when I say problem list, and I'm going to detail this a little bit more next time to make it a little more visual for you, because at least my brain, when I look at an algorithm, I just get all stressed out. But if I'm going to make it more visual, you'll see. This is an introductory to it, okay? So for each problem list, meaning the patients that see you may have multiple problems, right? So is it shoulder and hip and neck are we dealing with? Or I'm sure, how often do you see people with multiple issues that you treat? Or do you usually see them for one? A lot of time, yeah.
Especially hip, knee, and the ankle.
Yes, hip, knee, ankle, that's right. And so we have to be effective at diagnosing that. Number one, if it's hip, knee, and ankle, we have to know, is this hip, knee, and ankle, 3 separate issues? Or is it referred, right? Yeah, so we have to know, but they may have indeed multiple areas. So we have to come up with our hypothesis list for each problem, and then we have to think about how we're going to examine each problem. So what special tests, what objective measures, what data do I need to gather? Because do we know we're right all the time? Do we know that that's a good question. Yeah, I didn't make that right. Thank you. And everybody's staring at me blankly, so I know I didn't communicate that right. Do we know that the decisions that we make are correct all the time about a patient. No, right? We do the best we can, but that's why we have to have many potential hypotheses that we might shuffle back and forth, okay? All right. Okay, so for each problem, so how about, let's talk about goals. Good old goals. So how do you guys come up with goals for your patients? Long-term goals and short-term goals. Good. And how do you pick those goals? According to the exam. So give me some examples of some goals.
For revisions, and in acute phase, maybe just passive movements.
Passive movement. Good. Okay.
And we try to make the joint, the RM good.
Yes. So that would be a short-term goal.
Yeah, short-term goal.
And then turn that into a long-term goal.
Maybe with the muscles they are working, we can stimulate muscles. That can be we change the long-term goal.
Good. Good. And then you have to apply it to function, right?
Yeah, to function. Long-term goal just like from lying to sit, from sit to stand, stand to walking. That's a kind of long-term goal.
That's exactly right. And the other thing, so how about any other goals? Give me some more goals.
Such as frozen shoulder.
Sure.
Yeah, people cannot turn their hands up, and I think if we can make them rise up to 75 degrees or more, is a very good rule for the treatment.
Yes.
And different degrees can measure the patient's conditions, different conditions.
That's right. So range of motion, and then how would you turn that into like making it a functional? What would you add to that to make it functional? Yes, that's exactly right. Good. Yes. So you have to talk about washing their hair, right? So they're always looking for goals, and it gets confusing because we think of goals on our end as a PT, increased range of motion, right? But how will that range of motion affect that patient functionally? So they need to wash their hair, right? So by such and such a week, patient will wash their hair for 10 minutes. Well, I guess that's long. 5 minutes, without pain or something like that, right? So that's how you would write a goal. But what if the patient doesn't care about washing their hair? I mean, that would be, you think most people would care about.
Find what they really
Yes, and that was my point. Find out what they really care about. Because some people might not know, in the case of a frozen shoulder, like as PTs, we're always wanting to get to that end range. We're focusing on get all the way up here. The patient may clearly tell you, all I care about is that I can put my dish on this counter in my kitchen. If I can get my dish there, that's really all I care about.
I've had patients say, I don't need to wash my hair, I don't need to get on my shirt. And I'm like, how do you get dressed in the morning? I have an aide that comes to my house and does that for me. So they don't want to do it. They pay somebody to come in there, wash them, dress them, and give them their meal. So you have to think of what does the patient want too. If you want them to do it, guess what? And they're not used to it, they're not going to do it. So, outpatient is very different to hospital. If you have a patient that's been in bed bound for 2 months, that has a trach, they're on a feeding tube, they have wounds, what are some goals that you could set for that patient? Very low level. So you have to start from square one, from a small goal. What could be a short-term goal you could set? They haven't been out of bed yet. What are you going to work on? Okay, it's taxing just for them to roll, so you can work on rolling, so that maybe a CNA or an aide can come in and start, changing them, cleaning them up. And once they get to rolling, supine to sitting edge of bed for 5 minutes. Their body is going through a lot of recovery. They may have a lot of cardio problems, pulmonary problems. it's very taxing on their body to sit for 5 minutes. And guess what? You're going to be helping them sit on the bed for 5 minutes. And then guess what? After you're done with that treatment, they're exhausted. So it's a very different world from outpatient to hospital. You know, seeing those patients, they're very, very sick, and just doing those little movements may wipe them out for the rest of the day. So it's just those, you got to work on baby steps. You know, Jess is used to having patients walk in. I'm like, oh no, there's 2 of us getting this patient to walk today. And she's like, wow, I'm just not used to that. So it's interesting to, you know, break down gait and things like that we'll be working on.
I do think that's why you're going to like this class. I hope you do. Because our backgrounds are so different. So we're going to bring both worlds to you. And, I mean, then apply it just to the foundation. So hopefully you'll get kind of a bit of everything you want. And the reality is, like, even in my setting, I might have had a patient that came from that setting, right? And it's very important. I am aware that this was how long that they've been in the hospital for months, and they're very deconditioned. So when I want to put them on the bike for like 10 minutes, maybe that's not good. You know what I mean? So, yes, so coming up with those goals are very important, but goals that are what the patient wants. And it's not that we let patients tell us how to treat them or tell us what to do. We're not doing that, but we're honoring the human being in front of us, and we're honoring their world, and their world may be different than our world, and we have to respect that, right? Okay, so good goals. Okay. Okay, so tests and measures. So what kind of tests and measures do we do in therapy? What kind of things are we testing? So what are we going to take our patients through? What's our objective exam? What kind of things do we do in an objective exam? Am I making sense here? Probably not. So this is your objective part. So you've gotten through the subjective part, you talked to your patient. Now you're starting to think, what do I want to do with my patient? What do I want to put them through to figure out what's wrong, right? So in the case of the frozen shoulder, I'm going to look at their neck, right? I'm going to look at their thoracic spine. I'm going to look at their shoulder. But I got to look at other regions and take them through all those things and clear it, right? To know that I'm not messing up, that it's maybe indeed a frozen shoulder or not. If it's the case of the acute patient, what kind of tests and measures would you take your acute patient what happened to them?
They had a stroke.
Okay, they had a stroke. Totally different tests and measures, right? But what kind of tests and measures will we do with a stroke patient, an acute stroke?
Foundation things such as the range of motion, the tension of the muscles, and with about the aerobic.
Exactly. Good. So she gave 2 different examples because it depends on what the patient in front of us, right? So, right, they may be unable to move, and that exam is going to be entirely different than a patient that's a little more functional that might have the capacity to walk. We might check a gait that day. So you have to have a good sense of where you're going in your objective exam, and you gather that from the subjective, from talking to your patient, and also knowing the history of the problem, of how this happened, how they got here, right? So we're gathering that important data, right? Okay, good. Okay, so predictive criteria. So what are predictive criteria? What does that mean? What kind of data do we gather? Speaking of data, what kind of data do we gather that might tell us if a patient's going to get better, or if they're maybe somebody that might develop a chronic problem? What kind of things do we think about?
Or the differences, atmosphere changes they test during different times.
Different atmospheres, right? Yes, that's good. Yeah, how they respond. Mm-hmm. What other things do we take into consideration other than just the patient? I know, I'm being vague because I want you guys to get thinking on purpose. So if a patient comes to you and they say, let's say they came to you and they had a shoulder, let's go back to the shoulder, right? And they say, I'm never, ever gonna get to play with my kids ever again. I know it, this is it, this is the end. I'm never gonna be able to, this is so bad that I'm never gonna be able to play with my kids again. Compared to, yeah, I'm all right. It's sore and I can't really move my arm around very much. Of those two patients, which one instinctively do you think is going to get better faster? The one that says, I'm never going to play with my kids ever again, this is the end. Or the patient that says, it's not that bad, I just can't move my arm. Yeah, right? So what we call that are those yellow flags. Yellow flags are catastrophizing, meaning that the patient thinks it's the end of the world or they're exaggerating the issue at hand, but they believe that, right? They believe that this is the end of the world, or they believe that this is how they're going to be forever. If they have high fear, they're very afraid. So if you're a stroke patient, how scary is that, right? So I would imagine fear would be a huge thing that you would deal with.
They're afraid they're gonna fall. Their balance is definitely off. So you have to build their trust of, let's sit at the edge of the bed first, and then build their trust to get them stronger and to transfer them. So you really have to know your patient and, get the criteria of, reassure them that it's gonna be okay, I'm here to help you, and reassure them. Because it is very fearful. I mean, they've been through a lot, and then now they're gonna be sitting at the edge of the bed, they're like, oh my goodness, I haven't moved for 2 months. So, it's eye-opening for them.
Yeah, so if you have those clues, and there's different scales, and we'll go into that too, that you can use to help you gather data for research, or just data in general that can help you pick up on a patient that might have a high catastrophizing nature or have high fear or different variables. Because that patient, if we can pick up that they might have the likelihood of becoming chronic, we can change our eval and we can change our treatment with that patient, and actually it's been shown to prevent that from happening, right? Our exam is going to be different. So it's important we identify those things, because how we talk to the patient at that point and how we go forth will change, whether it's somebody of low irritability, and we'll get into that, versus somebody that's really highly irritable or has some other issues at hand, okay? So it's good that we think about that, okay? And it's also good that we know, again, if a consultation's needed, we're still thinking about that, okay? Reassessing, coming up with problems and goals. So intervention strategy. So let's say the patient, now we've evaluated them, we've indeed said that they have a frozen shoulder. What's our intervention going to be? How do we decide what to actually do to the patient that day to get them better? Yes, range of motion, mobilization, good. What else?
Strength training.
Strength training. Yeah. Now, do we just do it just to do it because we learned frozen shoulder, then we follow this? Or do we do patient that has this impairment and we do this, followed by this exercise? I know I'm challenging you. I'm going to get you to think a little differently, but we're going to work on that next time, okay? But stroke patient. So let's think our stroke patient. So it's an acute stroke, high fear, right? So what interventions might we do that day? Now that we've evaluated them and we know this is, the patient's non-ambulatory, pretty acute, afraid.
You can get them sitting edge of the bed. They need a little bit of help.
We think it's absolutely important to make sure that it can help to maintain the about and can prevent some further issue injury.
Yes.
According to the loss of function.
That's right. That's right. Good. So it's important as we do our exam that now in our mind we've figured it out through the subjective. We've gotten an idea of where we need to go with our evaluation, what we need to evaluate, and now we've established some goals based on what the patients kind of told us that they're interested in achieving. And now we've done our objective exam, so we've identified different impairments that are there that we need to work with. And now we're going to start treating them, right? Yeah. So that's kind of just showing you kind of how we go about this. Okay. Coming up with our plan. All right. So, why would we ever repeat an examination? Do we do that?
Yes.
When do we repeat? That's right. Yes, we'll do like for a re-exam. Exactly. What else? When else would we do? How do we know we're going on the right track? We're making a change. Can we tell that the first day? If we got it right. So let's say we treated our acute stroke. This is hard for me to apply to it. I'll go to the frozen shoulder because I'm better at that one. Yeah. So in our frozen shoulder patient, right? So how might we know after we did our joint mobilizations and we did a little strengthening, we did some range of motion, how might we know that we are doing the right thing, that we did something that was good that day for that patient?
Patient's feeling and examination again.
Pain and what?
Yeah, and the degrees or the moments.
The degrees of motion, right?
Yeah.
Yes. So we call that test retest. So every day in session, you should get a baseline of where your patient is that day, pain level, whatever functional thing that you're dealing with, right? Get a baseline before you even start. Then you're going to measure, you're going to do your treatment, and then you're going to get a second baseline. Where are they now? If they tell you they went from a 4 out of 10 to now they're at an 8 out of 10, is that what we want? Probably not. We made a, maybe depending on, yeah, that's good. Maybe depending on the acuity, right? So if they're low, I might want to mess with them a little bit. But, so it varies, it depends, and we'll go into that too. But we need to always keep track of where we are with our patients, so we're constantly testing and retesting ourselves so that we don't go and treat them for a month and not really get anywhere with them. So how might that apply in your world, like test retest?
As far as, getting the patient supine to sit, so you're checking their vitals. Are their vitals stable? If they're stable throughout treatment, you're on the right path. If something happens where you're sitting them there for 10 minutes, and guess what? Their vitals are plummeting. They're going down. Something's going wrong and you're pushing them too much. You need to lay them back down. So those are the triggers that you're going to focus on. What is their pulse ox doing? Is it stable? Is it gradually coming down? Those are things you still have to monitor. Okay? Are they requiring more help for them to sit edge of bed? Getting them up. Initially, they needed minimal assistance, but guess what? Now they're getting tired. They need more help. Like pushing them too much. So those are like the red flags you need to kind of constantly reassess throughout your treatment to see if their treatment's on the right path. And you're doing that weekly. And in the nursing home and the hospital, you see those patients in and out. So you usually see them weekly, definitely monthly, updating their goals.
Right? Makes sense? So if you get into that test retest, and we'll talk about that throughout the course. But when you do that, you get a quick sense of whether you're on the right track, you're doing what you should be doing, or, ooh, I didn't do a good job with that. I gotta think about it a little bit more, right? So that's that reanalysis and examination again, okay? Patient's progress, what strategies were appropriate and effectively applied? Were our goals appropriate? Are we getting where we want to get with our patients? And so this will lead to whether we want to change our goals or change, where we're going, okay? So this is a simplified version. Collect data, have the patient and family tell you what problems the patient has, develop our hypotheses, choose examinations to test, reassess, and repeat. Okay? Choose your measures, impairments, evaluate, diagnose, set your goals, and determine your interventions. Re-examine again. So, any questions about that?
Yeah.
Yes.
Just like frozen shoulder again.
Yeah.
And if maybe the patient's condition maybe become better after the treatment, but we cannot know it is a long-term treatment or short-term. You know, such as some people's frozen shoulder are caused by their neck, and their pillow is not very good. And after sleep, their symptoms become heavier, and maybe tomorrow he come back to our clinic and he said, I feel much pain. And after the treatment, actually I feel released, my pain is released. But I come back and I feel much more pain. And during this time, how could we do the examination?
I like that. So that's a really good point. So you're getting short-term improvement is what you're saying. So in session, the patient does well, and they feel great. Then they go to bed, and the next day they wake up. But the problem you're saying is
heavier, stronger.
The pillow or something like that. So how would we know in that case? Or questions? How would we know to go there? So what I would do in my mind is, first of all, and this gets into the orthopedic, and you guys are going to learn this from Dr. Martin. Trust me. So good. So anyway, when it gets into the spine, there's different tests and measures that we would do in that patient, and we would take them to really end range overpressure, really provoke it, tease it out, because you have to prove to yourself as a clinician that it isn't the neck. My training, it's the spine until proven otherwise. Whether it's any extremity, it's the spine until proven otherwise. So meaning...
This audio is made with Audio Toolkit for Windows Store, downloaded for free now.